Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational program titled Contemporary Management of HIV 2021. During this podcast, Dr. Daniel Kuritzkes from Harvard Medical School and Dr. Michelle Cespedes from the Icahn School of Medicine at Mount Sinai in New York discuss new ART data from virtual CROI 2021, including data on first-line ART and from the Atlas 2M and Capella trials. For more information on Drs. Kuritzkes and Cespedes and a link to the full online educational program, including downloadable slides, please visit the show notes for this episode. Now, let's get started and hear what Drs. Kuritzkes and Cespedes have to say about new ART data from CROI 2021.
Great. Well, thanks very much. So let me go straight on here. So the first of these presentations is actually a bit of an extension of what we talked about earlier with injectable cabotegravir, because this is another study of long-acting injectable antiretroviral drugs, but now for treatment of HIV infection rather than for prevention. This is the Atlas 2M study, the 96-week follow-up of Atlas 2M, which was a rollover study from the original Atlas trial of injectable long-acting cabotegravir and long-acting rilpivirine given to individuals who had been suppressed on an oral regimen and then enrolled in this trial. So what Atlas 2M was is people who either had already been on injectable monthly cabotegravir rilpivirine or who transitioned over from the oral control arm or entered into Atlas 2M directly, having been on other oral therapy, not as part of Atlas, were randomized to either get continue on or start monthly injectable therapy, or to get every other month, every Q8-week injectable therapy. And the primary endpoint at week 48, which had been previously presented, showed that the every 8-week dosing was not inferior to every 4-week dosing. And then what we heard at CROI this year was the longer-term follow-up at week 96, and follow-up is continuing out through 152 weeks. So at week 96, just as we saw at week 48, the every 8-week arm was non-inferior to the every 4-week arm. Because this was considered a switch study in the way that the trial was designed, we're really comparing rates of confirmed virologic failure. So there was 2% versus 1. And as you see on the right side, that meets the non-inferiority margin, which here is very tight. It's a 4% margin. And the more traditional endpoint of virologic success, or how many people were less than 50 copies, shows that it was 91 and 90% virtually identical numbers. Now, there were, and it's important to note that in the second 48 weeks of follow-up, there was only a single additional confirmed virologic failure. However, in the study overall, there were 9 failures in the every 8-week arm, and 7 of those 9 had evidence of resistance-associated mutations for rilpivirine, and 5 of those 9 had RAMs for the integrase inhibitors. That compares to 1 of 2 in the every 4-week arm for rilpivirine, and 2 of 2 in the Q4-week arm for Instes. Very small numbers, so hard to make a direct comparison there. In terms of safety and tolerability, for adverse events relating to withdrawal, you can see that those were, excluding injection site reactions, those were relatively uncommon. And then if we look more specifically at injection site reactions, first of all, there were, as you might expect, from every 8-week instead of every 4-week, there were roughly half the number of injections given in the Q8-week compared to the Q4-week arm, but still, tens or thousands of injections administered. Overall, there were roughly a quarter of the people had injection site reactions at some point. These were mostly pain, rarely nodules and other kinds of reactions. There were very few grade 3 or worse injection site reactions. And these reactions were generally short-lived and very infrequently led to withdrawal from the study because of these ISRs. And the rate of ISRs did seem to diminish with time on study. As you can see, roughly 20 to 25% in the first 48 weeks and 12 to 16% in the second 48 weeks of follow-up. Another study that had long follow-up presented was the use of the single tablet formulation of bictegravir FTC TAF as initial ART. Here we're looking at the 4-year outcomes. This pooled data from 2 randomized phase 3 trials that had open label extensions. And so the data from the 2 BF TAF arms are being pooled for analysis, as well as people originally in the control arms who then rolled over to receive open labeled BF TAF during the extension phase. And what we see, not surprisingly, is that nearly everybody maintained virologic suppression throughout the 192 weeks of follow-up. What you can see with the change in colors here is that the original control arms are shown in orange and green, and then everybody turns blue or blue-green as they all end up on BF TAF. There were no emergent resistance mutations to any component of the regimen in any of the groups. One person who switched, who had been on dolutegravir or bacavir 3TC, developed a 184V mutation, but not dolutegravir resistance, and that person suppressed after switching to BF TAF. And efficacy was maintained in participants who switched from a dolutegravir containing regimen to a bictegravir containing regimen at the week 144 or later. In terms of safety and tolerability, there were some minor side effects of diarrhea, headache, some upper respiratory infections, and occurrence of syphilis, not due to drug, but in people receiving drug. And then also, as in terms of adverse events that were considered to be drug-related, these were nausea and diarrhea and some headache. There were some small number of people with lipase elevations. These are now here looking at absolute numbers, not percentages, and a small number with increases in creatinine kinase. If we look at weight gain, which has become an important issue, there was about a 3 kilo weight gain in the first 48 weeks of study, and then 1 kilo per year. That's very consistent with previous trials. Recall that a gain of about 1 kilo a year is pretty common for many adults with or without HIV infection. And then there were very modest declines in spine and hip bone mineral density, with a median change of less than or equal to 1.4% over the entire 4-year period. Turning to a completely novel therapy, the Capella study was a phase 2-3 trial of lenacapavir, a novel first-in-class HIV capsid inhibitor in heavily treatment-experienced people with HIV. This study, which in the past we might have referred to as a salvage therapy trial, used a study design that's very similar to the design that was used for the Bright study of fostemsavir, another trial in heavily treatment-experienced patients that we've discussed in previous programs. So here, people who were highly treatment-experienced and had resistance to at least 2 agents from 3 or more classes, but still had 1 or 2 fully active agents for use in a background regimen, were randomized to either continue on that regimen or to add lenacapavir for a 2-week period. during which the change in virus load was determined. And then everybody received lenacapavir and optimized their background regimen and continued to be observed or to be followed. The initial dosing was oral, followed by subcutaneous administration every 6 months. So this is another long-acting agent. In addition, there were people who were directly enrolled into the lenacapavir arm as an observational arm without a randomization component, and they were counted or analyzed separately. And so the primary endpoint was, and the primary objective was achieving a half log reduction or greater at day 15, the end of this initial 2-week dosing period. What you can see on this slide in terms of the primary endpoint is that 88% of the lenacapavir recipients, as opposed to only 17% of the placebo recipients, achieved a half log reduction. And in fact, the actual reduction was on average nearly 2 logs in the lenacapavir group compared to just a 0.3 log reduction in the placebo group, demonstrating the potency of lenacapavir in this highly treatment experienced population. There were a small number, 2 of the 72 participants who received lenacapavir did subsequently rebound with emergence of a lenacapavir resistance mutation. The M66I mutation is now recognized as the most significant of the mutations that have been associated with lenacapavir. Both of these participants resuppressed when they added their optimized background regimen. Looking at the longer term follow-up, roughly 3/4 of the participants were able to, and this is looking at everybody in aggregate, both those in the original randomized component as well as the non-randomized cohorts, roughly 3/4 were able to achieve and maintain viral suppression to 50 copies or less. In terms of the safety and tolerability of the regimen, and here again, we're looking at absolute numbers, not at, I'm sorry, these are percentages on the left. You can see that there were some GI side effects as well as some cough and nonspecific adverse events. It's notable that the nausea occurred during the oral phase and was not observed during the subsequent injection phase. As far as the injections themselves are concerned, nearly half of the participants had one or more adverse events related to injection site reactions. The vast majority of these were very mild, just grade 1. There were no discontinuations due to ISRs, and you can see the overall distribution here. There were some nodules that occurred, and those did resolve over time, but took some time to resolve. So let me turn back to Dr. Cespedes, Michelle, and ask, so looking at the Atlas 2M data, assuming that a more extended dosing interval is approved by the FDA, what are your feelings about every 8-week versus every 4-week dosing?
Patients prefer it. It's almost to the point where I almost want to hold out even from putting people on the Q 4 weeks, all right, until we kind of work out the kinks. But if the plan is to be every 8 weeks, completely comfortable, partially because we enrolled and participated in Atlas 2M as well. And even for some of the short interruptions at the beginning of COVID, when patients had to briefly switch back to oral, they were right on board getting back to injections as soon as possible. So more than comfortable. Again, I'm surprised at how many people are looking forward to it, even people who are, well controlled and been taking their meds daily for years. I think originally I always envisioned it for our patients who were not compliant or had other competing priorities or psych issues or follow-up was an issue. But I think now with experience, it's almost like, is that the best patient, right? If we're not quite sure about follow-up and compliance with coming in every 2 months. But I'd feel comfortable and actually prefer it than even starting on this Q4 week. But we still have some insurance things to work out and implementation issues, and I think that's different from state to state.
Yep.
Have you guys started it in Boston as yet?
We have begun gingerly. Again, logistics and of course
Right.
COVID-19 have sort of all jumbled things up a bit. I think it's going to be important for us as providers to pose the question to our patients, because as you mentioned earlier, and again now, you've been surprised at how many people have been interested, and I think there may be greater reluctance on the part of some providers to consider injectable therapy than there is on patients to accept it. And so, I think if we're doing real due diligence, we should be asking our patients whether, rather than making assumptions about what patients might or might not prefer. What about the issue of weight gain? We've talked a lot about this over the last couple of years now, what do you make of the weight gain data seen with the long-term follow-up with the BIC FTC TAF?
I always take it into consideration that, we're supposed to gain some weight at a certain age. When I originally started seeing the data coming out, maybe it was 3-4 years now, and I was like, I've seen that once or twice, but not enough. And I don't think I was as mindful as I am now, or watching it, or I think also patients are talking about it, especially some of my female patients, or have some questions about it. But I do talk about kind of what we know now and compare to, the other options that we have. But I do talk to them about the possibility and the importance of kind of watching our weight and what we eat, and just being, American and New Yorkers and getting older. So taking that into consideration as well. But I do mention it. I kind of like don't hide it, or, just like we used to do with kidney function and risks. But I don't think I've not given someone an integrase-based regimen because of that concern myself.
And then what about the highly treatment experienced patient with multi-drug resistance? How many such patients do you see in your practice, and how many do you think might be candidates for a lenacapavir-containing regimen?
So over time, we were we had quite a few patients on the BRIGHT study, on the fostemsavir study. So kind of over time, as more regimens and more options come out, we're seeing fewer and fewer. Now, actually, some of our kind of like that last cohort of children who were born positive in the early 90s are kind of in their early 30s now. So sometimes they have the most resistant virus and aren't necessarily the best candidates or in terms of med compliance. But really, since fostemsavir has become available, and if providers have had something to add to it, to a backbone, we're seeing even some of our really, really highly treatment experienced who couldn't become undetectable for years, doing really quite well in it. So I think the pool is getting smaller and smaller as we go forward.
Thank you very much to Drs. Kuritzkes and Cespedes, and thanks to listeners for joining in today. As a reminder, to view the full educational program, Contemporary Management of HIV, on Clinical Care Options website, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you so much, and have a wonderful day.